series, and today we have Dr. Olivia Metcalf and Dr. Belinda Davey from the Centre for the Digital Transformation of Health, and they're doing Digital Health 101. As always, I want to respectfully acknowledge that we're on Wurundjeri Woiwurrung land and acknowledge the traditional owners of country and wherever you're joining from, and pay our respects to elder, past and present. And if you could pop into the chat of the land that you're on, that's always really interesting to see where people are joining from. Today we are, I hope the echo is just me. Today the learning objective is related to the capability around working with digital tools and digital technologies. So we're really keen to develop our skills and knowledge as mental health practitioners to engage critically, ethically and effectively with digital health in contemporary mental health practice. And our speakers are Dr. Belinda Davey, who's a research fellow at the Centre for Digital Transformation of Health, and Dr. Olivia Metcalf from the Centre for the Digital Transformation of Health. Thanks, people who are popping their country in the chat. So before I hand over to them, I just wanted to quickly do a poll, and I'll do one at the start and one at the end, on where we are with digital tools. So can people see the poll that I've put up? Polls. Save, relaunch.
No, yeah, they can't see it. Oh, one person's put thumbs up.
Poll has been launched. Can people see the poll? Just let me know. No. Okay, I'll come back to it a bit later, and in the meantime, I will hand over to Olivia and Belinda.
Well, thanks very much. Belinda, can you see my slides now?
Yep. They're not in presentation mode if you wanted to use it. Yep.
Yeah, should be. Is it now?
Yep, it is. Yep.
Oh, thanks everyone. Hi, my name's Olivia. It's nice to see you all. Thanks for joining. And I'm joined by Belinda as well. She'll be helping me out with the chat. We're from the Centre for Digital Transformation of Health. I would also like to acknowledge the traditional owners. And this is a photo of Sandra Aitken. She's a Gunditjmara woman, which is in the southwest region of Victoria. And she's holding an eel trap, which is 6,000-year-old technology. It's aquaculture technology and the oldest ever evidence of human technology that was built in an aquaculture setting. So I guess I just want to acknowledge that we're talking about very advanced technology today, but the first technology in Australia was from our Indigenous people. So I think hopefully if you're brand new to digital health or you're working really extensively in the area, there'll be something for everyone in this. I think it's useful when it's something as dynamic as digital health that feels like it's changing almost every single week. It can be useful to just start right at the start and even just start with a taxonomy. What do we mean when we say the word digital health? There can be a lot of misconceptions and a lot of myths, and so it's useful to start with a shared language. This is taken from the American Psychological Association, and they carve up digital health on the left-hand side in terms of health IT. So these are things that primarily are supporting clinicians or practitioners, wherever they are, to deliver the care that they're delivering, whether that's mental health or physical health. So that's things like electronic medical records, email, patient messaging or secure texting with patients, and of course, telehealth or video conferencing platforms, which have become really popular, particularly in the last 6 years. And then on the other side, they have a category of what they call mHealth, which originally was called mobile health and is really referring primarily to smartphones, but not just smartphones. It could also include websites or other forms of software that are delivered directly to the consumer. And so that includes things like wellness apps, wearables, and then digital therapeutics, which is apps that have a prescription or prescribed intervention for someone, as well as things like virtual reality. So a nice broad church there. It's not the only way to think about digital health. This is a taxonomy from the Australian Digital Health Agency. Similar in some ways, you can see some of the similar terms there, but the way ADHA has carved this up is to think a bit more about who's the consumer of that tool, who's the consumer of that technology. And on the left-hand side, you can think about industry and admin side of digital health. So this might be if you're working in a hospital or another setting, the back-end software that might be supporting the care that's delivered there. And then the orange column in the middle is a healthcare practitioner facing. This might at the moment include things like AI scribes. So it's not directly targeting the patient, but it's something that's supporting you with the work that you need to deliver, as well as other sorts of software that might help you deliver the care that you need to. And then there's a big category of stuff that's patient facing, and that includes things like wellness apps right through to digital therapeutics. So I guess the key point to make here is there's no one taxonomy. It is a broad church when we talk about digital health, so it's useful to think about it in that way. But actually the core thing that underpins all of these taxonomies, and indeed underpins all of digital health, is information, and more specifically data. So at its core, digital health is any hardware or software, any technology that allows you as a practitioner or you as a patient to send information, receive information, communicate information. With that really broad approach, it's also probably useful to say what isn't digital health. There can be, I guess, a misconception that digital health is just referring to med tech or medical technology, new devices, new hardware. That's not the case. It's including all forms of software. But it's not just advanced software like artificial intelligence, which we'll talk more about later on. It can also be, dare I say, ancient technology like websites and smartphone apps. And it's not just the infrastructure that supports software. So it's not just electronic medical records or whatever might be required to sort of power the program. And actually, when you look at it this way and you look at what isn't digital health, there's so little healthcare that is delivered today in Australia that doesn't in some way touch on digital health. So I would argue that all of the healthcare, mostly both mental health care and physical healthcare today, involves digital health. So it's everywhere and it's important. Why do we need it? Again, just helpful, I think, to go back to first principles for a second. If we accept the thesis that digital health is really about information, then we can kind of extrapolate from that and say healthcare, again, whether it's mental health care or physical health care, information is at the core of it. Delivering good care really involves getting the information that you need from the patient and providing information back and that important flow. So it's kind of fundamental in that sense. But also when you look at all the strategies at a state level, Victorian state level, national level, international level, however far or small you zoom out, all of the strategies at the moment are, they're concerned about a lot of things in healthcare, but two of the biggest concerns in the mental health space in 2026 are the challenges with the workforce in terms of shortages and really serious concerns about access and equity. And when you look at those two challenges and you look at all the strategies and ways that we're going to try and solve those problems, digital health is almost always considered one of the top ways, the top solutions, the top way that we're going to solve workforce shortages and the top way we're going to solve access and equity issues. And so it's really important that we get it right because it is kind of seen that way. And I love this quote. This is by Pat McGorry, who's one of Australia's preeminent psychiatrists. And I'm going to read it in full because I think it really captures, the hope and the promise that we have for digital health and mental health. So he's saying, the greatest hope is probably to improve access to psychiatric and psychotherapeutic care, especially in regions with limited services or for young people who have difficulties, to intervene early and at low threshold before crises escalate and become chronic, putting a permanent strain on the system. So it's a lovely summary because I think it's bringing a lot of hope, but also I think a lot of pressure for us to get that digital mental health approach right. So we've talked about digital health and the taxonomy and what it is, and now I'd like to talk about you because one of the themes of today is that digital health is not just technology, it's a socio-technical solution. So for us to get digital tools right, we have to consider the human factors. And I know I'm speaking to a lot of mental health experts who all probably have backgrounds in psychology and sociology and social work. So you all have a very good sense of how important the human is. But I think it's worthwhile right now checking in with us as we come to digital mental health and as practitioners. So this is a really great taxonomy developed by Tricia Greenhalgh. She's an amazing researcher over at University of Oxford. And she said it's useful to think about the orientation that you bring to digital health when you're trying to assess, the future, the promise, the hope. And so feel free, if you're confident enough to just mark up, you can annotate the bars down on the bottom of the Zoom slide, or maybe it could be at the top, depending on your screen, and it will say annotate. You can just go ahead and draw on there. Or if you don't feel comfortable doing that, you can enter the chat and just drop in what you think you identify as. And I'll just read these out and then we'll see what we get. So on the top left, there's the techno-optimist, which is a lot of what we just talked about. This is this, if you're a techno-optimist, you've probably seen this in the news. You identify that digital health is sophisticated and ubiquitous and failure-free. And you kind of hold this position that digital health will solve these big problems. That's a lot of what we see in strategies at the moment. And that's a lot of what we hear, particularly from industry, but also from other areas of healthcare. But in antagonism to that, there's also, I think, a lot of dialogue probably coming from that area of maybe techno-pessimism, which is this idea that digital health really needs to prove to us it's not harmful, and that digital health probably can't solve healthcare's biggest problems, or certainly wouldn't be one of the first solutions. Belinda, I can see you smiling, so I'm going to assume that some are coming through on the chat. Is that right?
No, I was just reading through and everyone's putting humanist. That's what I was smiling at.
Oh, I love that.
feel
That's great. You're the same, yeah. And then there's humanist and organizational. And these are they're interesting ways to look at it. Again, the humanist idea is that technology will work if we can get the individual needs of those consumers and clinicians right, and we can get them into their hands and get them to use it and uptake it. And again, sort of maybe in contrast, but or in comparison to that is maybe more of an organizational view, which I actually think I might be more of, which is that digital health is neither good nor bad. We're not taking a pessimist or optimist view, but the same technology will have very different outcomes and utility in different contexts, and less about the individual and more about the system, more about the organization. And for us to actually digitally transform Australia's healthcare system, we're going to need this additional work really at this organizational level. And the technology kind of comes second really to the individual as well as to sort of everything else. So it's really interesting and it's useful to think of, and you might switch between them based on the technology, but certainly putting the human factor into the technical side of it. Okay, so let's talk now about types of digital health, and there are loads, and so I've just picked 4 because we only have a little bit of time together. I want to talk to you a bit more about mHealth and some kind of promising, but also challenges that we're facing there. I'm going to just touch on VR because you're going to hear about that more in the rest of the sessions. I want to talk a little bit about digital phenotyping. That's been some of my work, so just kind of share the potential there. And then we're going to talk a lot about AI. So let's start with mHealth, which again is one of those categories of digital health, if you remember the taxonomy from a few slides back. Why is mHealth a useful potential kind of tool to manage people's mental health and well-being? We know that 90% of Australians have a smartphone. They have primarily Android or iPhone smartphones, and the majority of them are internet connected. So they have the hardware and the access that would enable them to leverage a smartphone application or something that pairs with a smartphone. And so kind of hand in hand with that, at the moment, if you open your phone and have a look at the App Store, you'll probably find around 100,000 mHealth apps that would be available to download. And so this is for all sorts of physical health conditions, including mental health. And it changes every day, but up to 20,000 of that 100,000 would be focused on supporting someone's mental health and well-being. So quite a lot of apps is my point. The vast majority of that 20,000 are not intended to treat a mental health condition. So these are really under that huge umbrella of well-being apps. You've probably seen them. You probably use them yourselves. Maybe you like them, maybe you don't. Again, feel free to drop in the chat if there's one in particular. I know there's some really big names out there with these, and they tend to focus on skills that are useful, that are evidence-based, that we know can improve psychological well-being. And that's things like habit tracking, gratitude, journaling, meditation, and promoting physical activity. So overall, some pretty promising in terms of the coverage there. On the other flip side, only about 2% of those 20,000 apps have published evidence of effectiveness. And I suppose whether you're an optimist or pessimist, you might see 2% as not very good. Another way to look at it is that that's hundreds of apps actually have published evidence of effectiveness, which I suppose could be promising. And, there's small effect sizes in the reduction of depression and anxiety symptoms for apps that are targeting those. And then there's also RCTs that are reporting benefits in these sort of transdiagnostic skills like emotional regulation, mindful awareness, psychological flexibility, all of which we know can be really valuable regardless of someone's mental health status. Within that category of apps that have published evidence of effectiveness. There's a very small number of what we would call digital therapeutics. So this is where the smartphone app and any accompanying, wearable or hardware that comes along with it has published evidence of effectiveness in reducing symptoms. It can be prescribed by a mental health practitioner in the United States and in some other countries. And they've gone through the FDA in the United States, quality and safety in terms of that product. So this is a much smaller number of apps because of that threshold that's required. And you can see some of them there. Nightwear is a really interesting one. It works by being paired with a wearable. And as we know, folks who have PTSD typically have quite significant nightmares that are distressing and disabling. And the way that the app works is that the wearable detects when the user is entering into REM sleep or a state of sleep where they're likely to have a nightmare, and will subtly vibrate, not enough to wake the individual, but enough to move them out of that sleep cycle. And so it's been shown to be very effective in reducing intensity and severity and a number of nightmares without disturbing sleep. So that's one really neat example, but there's lots of others in substance use and other sorts of mental health issues. So that's great. There's lots of promise there, and we're kind of, moving forward with more effectiveness. But I guess the flip side, I think, to talk about is this example here. So this was internet-based cognitive behavioral therapy known as Sparks. So this wasn't delivered on a smartphone. It could be delivered on a smartphone, but it was also delivered via a desktop computer, so under that category of mHealth. And this was a nationwide study where they implemented this free, evidence-based, internet-delivered cognitive behavioral therapy for adolescents with depression, and the product name was called Sparks, so that's what they're referring to there. After 7 years of availability, this group here did an evaluation of sort of the uptake of this product. And what they found was that even though the tool had been available for 7 years, and it was offered without a referral, and it was offered at no cost, and it was offered to every single person in New Zealand who had a New Zealand IP address, so the whole population, only around 2% of the population registered, and a much smaller number of folks actually completed the modules that would be required to be considered a dose. So that's sort of challenging because there's this tension between this concept that if we just create and build and develop, really evidence-based, free, effective, safe mental health tools, under that mHealth umbrella, people will pick them up and use them because they have the internet and they have their smartphones and they have desktop computers. And so what could be the barrier? So I think it's important to interrogate why, because this isn't just an isolated case. That actually, if you look in the literature, there's quite a lot of evidence that there's a bit of a translational gap between what we think mHealth can achieve and what impact it seems to have in the real world. And so I'm going to keep returning to this image as something I think that really underpins the challenges of digital health and certainly digital mental health, and that's these two translation gaps. You might be familiar with them. This paper is more than 10 years old, but it showed that when you've got an idea for a technology and you want to get that technology implemented in whatever clinical setting it is, or whatever setting it is, in the public health space or whatever it might be, there's actually two, for want of a better word, kind of death valleys that you can go through. And that is, it's so hard to get the idea through to early pilot evidence of effectiveness. But even when you achieve that and you've got good evidence of effectiveness, there's a really hard translational gap in terms of getting that into the hands of the users. And again, we'll kind of return to this. At the University of Melbourne, we're very concerned about this gap because we think there's a lot of potential. So one of the things we've been working on is to try and figure out how we can overcome it. And I think here it's helpful to when we're asking the question of why do these digital interventions that have so much potential not always translate into outcomes, it can be helpful to think about how we bring other interventions to market. And what I mean by that is to think about the drug development process in terms of pharmacological agent. So say, for example, you're a researcher or a clinician and you want to bring a new drug to market to treat depression. You have a very well-worn pathway, blueprint that you need to follow in terms of what evidence you need to generate, at what time point, and with whom, in order to make sure that drug is coming to market in a safe and effective way. And that pipeline has been in existence for over 80 years. So we've really refined the science, we've really refined the methods that are required in order for that to be a safe and effective pathway. But we don't, when we look at digital health and developing a digital health intervention, so, you want to develop a new smartphone app or, any other kind that we'll be talking about, it's much less clear. And some of the methods that we used might not always apply, or might not always be useful. And so this is some of the work that we think academia kind of needs to do to support bringing digital health through to effective clinical implementation, which is to help researchers and clinicians who want to develop a tool to really understand what evidence they need to generate and when, and develop the methods of that alongside the actual tool itself. And we think this is the reason why some of the promise of digital health at the moment hasn't quite translated, because we don't really know how to develop things properly and safely and implement them effectively. And we have an idea, we have a sense, but we don't have that well-worn pathway. And there's, as I said, when you kind of scratch the surface, you can see it's not just that Sparks case, which is isolated. There's actually loads of examples of how that promise of digital health hasn't really translated. So we know that if a digital tool does not fit within the workflow of a clinician, and I'm going to assume that amongst the people online, there's several clinicians, or you're all clinicians. So again, feel free to just dump in the chat the time, if you feel brave enough, the time someone tried to introduce technology into your workflow and that drove you mad. We see that. So actually clinicians are the top reason why a new digital health tool will not get adopted in a clinical setting. And not because they don't like it, and not because they don't want to, and not because they can't see the value, but because it doesn't fit within their workflow, or no one has explained to them how it fits in the workflow, or they have to kind of come up with all these workarounds. So that's a huge problem. How do we understand the workflow of clinicians so we can elegantly fit in these new digital health tools in a way that doesn't create barriers? We also know, looking at consumers, that most consumers will abandon an app only after about 5 days, and that's because they find them too burdensome. So it's not enough to just know that they have a smartphone and then deliver them evidence-based content. We have to be doing it in a way that's usable and feasible. And 70% of FDA software as a medical device that's recalled is recalled from usability problems. So it's really, I think that's a really interesting statistic, because it's not recalled for technology problems. The majority of time software is being pulled off is again, those human factors. So hopefully this is kind of convincing you of that case of how important it is we address these human factors when we're designing and developing digital tools. Okay, so that's all I wanted to say about mHealth, and I guess I wanted to just end with that here and say, as a clinician, you might have, well, we know that individuals with mental health issues, they're interested in using apps to support their well-being and their mental health, and we also know that they are already using them. And so for you as a clinician, of course, that doesn't mean you need to support or endorse or adopt the use of apps, but I think we should prepare the workforce to be prepared to answer patients' questions about apps, and be prepared to facilitate shared decision making around apps in this person's mental health and well-being journey. And so this is from this App Advisor. I encourage you to look it up if you're interested. They have a really, really simple, easy to use resource. It was created by the American Psychiatric Association, but it's, any mental health practitioner could use this really easily. And it kind of asks you in these categories, you can see down the bottom of the screen, in really simple ways to think things through. Like, if you're interested in this app, or your patient's interested in this app, simple early questions you can think about is the app designed for Android or iPhone, and what kind of phone does my patient have? And then you could ask other questions about, does it require internet access or download, and is that feasible for them? And then you kind of work your way up through these questions, and it helps. You don't have to be a technology expert or a regulatory expert or anything like that. It really just walks you through the kinds of questions you can ask to determine together, is this app potentially effective, and how to interrogate, I guess, the evidence and the advice around it. Okay, so that was a bit about mHealth. I'll just talk quickly about VR, again, in the spirit that you're going to hear a lot more about it in this seminar series. I think it's useful to talk about it. Is, of course, a really important burgeoning area of digital mental health. In essence, virtual reality, if you're not across the details of it, it just creates this immersive real-world simulation. And the point of that is, in one whole branch of VR, it's for fun and it's for games, but in the mental health space, it's so that therapeutic skills can be practiced in this really safe way. Sorry, my screen's just come up. So my own technology is not being helpful to me. And so this is valuable because it can address some limitations we know exist in traditional care, which is that it's hard to learn. It's challenging, can be challenging to learn skills in clinic and then have to try and apply them later on in life. Now you can do that in the one space. And there actually is a fair amount of evidence now that supports virtual reality-based interventions across different mental health conditions. It's important to note that most of the evidence is still for clinician-guided therapeutic use. There is some interest, could we have these standalone consumer apps? So could there be a place where consumers are ordering virtual reality goggles on Amazon and then they're downloading the app and they're working through skills themselves? When I don't think the evidence is quite there yet. It's an interesting idea. We'll have to see. But certainly it's primarily with clinicians supporting patients. And with that comes challenges. It comes challenges with cost and challenges with scalability. The cost of developing these real worlds in virtual reality can be costly, as well as the hardware itself. So that's just an intro. Again, hear a bit more about that later. I wanted to also just take a second to talk about digital phenotyping. I think it's an interesting area, and it also feeds really nicely into AI, which is what we'll do for the rest of the session. But if you're not familiar with the term digital phenotyping, which I agree is a bit of a clunky term, this can be one way to sort of think about what it is. If you look at your smartphone now, wherever it is, maybe you're on it or at the moment looking up mental health apps or whatever, you can see how much passive data is collected from or capable of being collected from that smartphone. So here's just an example of some of the pieces of data that can be collected from your smartphone. Light sensors, temperature sensors, accelerometry, how fast you're moving, whether there are other devices near you, which is a really good indicator of whether there are people around you. It can do that by detecting other Bluetooth-enabled devices, GPS, so it can tell your location with pretty good accuracy, as well as lots of other things. And so what digital phenotyping means is, because we have our smartphones at our fingertips and we're engaging in all this behavior as we move about in the world, and our smartphone is capable of collecting that, all of that data could come together to be a type of phenotype. You could work, using data, you can derive someone's digital phenotype. And you can also pair that with self-reported data. So smartphones, in addition to, of course, collecting all this passive data, can collect really subjective measures of behavior, suicidal thinking. And so there's been a lot of work trying to emotions, other sorts of things that might be relevant to the disorders or the behaviors of interest that you have. And so here's just kind of one really simple example. This is from a really great postdoc at the University of Melbourne. And this was using smartphone data to try and understand how people experience dysregulated anger. So this is in Australian adults who have experienced trauma. And we know that after experiencing a traumatic event alongside PTSD, people can develop really dysregulated anger. It can be a symptom of PTSD. And so what you're looking at here, each line is a participant in the study. We had 60, this study had 60 participants, and each box is a roughly 3 or 4 hour window. And when the box is gray, that means the participant didn't respond. And so you can kind of automatically see that quite a lot of data was collected on their symptoms throughout the day. We collected the data over a 10-day window. So that's how many boxes are represented there, roughly 40 for each participant. And then blue indicates that they didn't have any anger, and it goes all the way up to dark red being very intense anger. So you can kind of immediately see you're able to capture symptom data or whatever data that you're interested in at a really high resolution, and you're able to get metrics on how people are thinking and feeling and behaving in the real world in a way that you just can't access when you use kind of standard psychometric measures in a clinic. So it has digital phenotyping has really tremendous potential in that you're able to get data on people in the real world, and you can often collect it very unintrusively because you're just collecting it passively from the smartphone, or you can collect it really easily from self-report. But of course, just to come back to this image, as cool as that is and as exciting that is, I think there's still big questions around, well, how do we translate into something that, can be effective? And then once we establish it's effective, how do we implement it? There's lots of questions like how would that be useful for the workforce? How would you interpret that information? How would you use it to change treatment? We haven't really grappled with a lot of those questions. So now is probably a good time to talk about AI. Why not? And again, starting right at the start, I think it can be useful to just share a taxonomy around AI. So when we're talking about the term AI, you might already know this, we're really talking about any technique that enables computers to mimic intelligence. And this is a very unhelpful term. You might already know this, but the word artificial intelligence is a term so broad that captures so many different things. It doesn't always give us the nuance or specificity that we need to really understand what we're talking about. So when we say, oh, we've got this AI tool that we're going to bring into this clinic, that's not the best way necessarily to use that term because it doesn't really tell us what it means. So the first thing to note is that the word artificial intelligence refers to a lot of software that has already been in existence for decades. And there's probably some in the clinical systems that you're working in, and it's just using things like if-then rules, decision trees, which is, really simple, I guess, if I can use the word simple artificial intelligence. It's in these next layers down, particularly things like machine learning, deep learning, and generative AI, which is actually typically what we're referring to when we're using the word AI. So machine learning, if you're not sure, is a subset of AI that just uses statistical algorithms that enables machines to improve at tasks with experience. And again, some of those statistical algorithms have been around for decades. Belinda's a data scientist and she works a lot with these. And so some of these stuff is not new. It's been around for a long time. And then within that, we have deep learning, which is a subset of machine learning. And that's using multi-layered neural networks that can train themselves to perform tasks on vast amounts of data. So in that category of machine learning, in that category, when we're talking about deep learning, it is a subtype of AI and it's using much larger forms of data compared to the others. And then within that, we have generative AI, which is a type of deep learning. And again, it's in the name in terms of what's happening. It's generating new content. And right in the center there is ChatGPT. If you've, the most well-known of generative AI, that's a type of generative AI, but there's lots of other vendors and products on the market. And there is some generative AI that's not just creating words, it's also creating images. So I think this taxonomy is useful, and it's useful for you to start interrogating as AI comes more and more online. And as people talk about AI more, one of the first things you can ask is, well, what's under the hood? And is it a machine learning algorithm? Is it a deep learning algorithm? Are they talking about generative AI, or are they talking, they're talking about ChatGPT? And just kind of having that understanding without needing to be a data science, I think is already helpful. And I thought I'd also say something, I don't know, maybe this is unnecessary, but I would like, I always to kind of take that first principle of, well, why do we even need this? So AI, everyone's very excited about AI, but why would we even consider including AI in our mental health care or in our healthcare system? So I want to kind of propose that at the moment, we're in a strange situation where we actually have an information problem. And maybe that's a bit cheeky. Maybe always more information is good, but I think it's a good way to think about it. In the 90s, before computers were widely used, the average number of facts that a healthcare professional would make a decision about for a patient, deciding which disease they had, which condition they had, which treatment they needed, or what should happen next, they would have on average around 7 pieces of information for which that they would make that decision. And that worked really well because the human cognitive capacity, as you probably know, is around that mark. There's probably about 5 to 7 facts we can hold in our mind at one time in terms of making a good decision. When it gets beyond that, our cognitive capacity is overstretched. But since computers have come online in the 90s, we've seen this explosion in the amount of information, which makes sense because, computers are at its core capable of digital health. So we're collecting more and more information. And this graph needs to be updated because it's nearly 20 years old. And since the omics revolution with, genetics and proteomics and all the other omics that we now have on top of that, of course, our digital phenotype. So there's an almost a limitless amount of information that can be collected biologically, physiologically, and digitally, as well as more from our patients. And that creates this enormous amount of information. And then, of course, the human cognitive capacity is completely unchanged and at this point won't be changing. And so that means, it's not a coincidence. It's in lockstep that as the amount of information we collect in the healthcare system has grown, so too has the need for us to develop these algorithms or these methods that can handle these vast, vast, vast amounts of data. So I hope that made sense, and I hope that was, useful as a taxonomy, again, to think about, at a surface level what AI can do. But I want to talk now about, so the opportunity is that it can synthesize these massive amounts of information and uncover things that we didn't know because our brain couldn't process those amounts of information. I think that's exciting, but it's worthwhile pausing. And again, not from a techno-pessimist perspective, but just in a reality perspective, and talk about how these algorithms can also go wrong. So you might be familiar with this case. Again, this is 7 years old, which is positively ancient in the history of AI. But I'm just going to share it with you because I think it's a really nice early example of what we need to be alert to. This was in the United States. This was a machine learning algorithm. So now you know where we are in the taxonomy. This was a machine learning algorithm, and it was used by healthcare decision makers. So this algorithm, was right on the left-hand side of that taxonomy in terms of who is the user. This wasn't being used by clinicians. This wasn't being used by patients. This is an algorithm that was designed to detect which patients needed to be defaulted into a high risk care program. So it was designed to support patients who had multiple chronic conditions and needed extra care, basically. And it was rolled out in a number of United States hospitals, and it affected the care of millions of patients. So I understand that this algorithm was in deployment in hospitals for around a year until a postdoc, a really brilliant postdoc from, I believe, from Stanford said, "Oh, I want to evaluate this algorithm that you've got running in your hospital. Would that be okay if I do an evaluation?" And the hospital said, "Sure." And long story short, you can see on the right-hand side, this is what the evaluation showed. So after this algorithm had already been running and making decisions about which patients needed this program and which patients didn't, you can see that Black patients, which are represented on the purple line, and white patients, which are represented on the yellow line. And just to clarify what's happening here, white patients needed to be half as sick as Black patients to be defaulted into the program, according to the algorithm. Whereas, the other way to talk about it is that Black patients needed to be twice as sick as white patients for the algorithm to detect that they needed to enter the program. And so why did this happen? I mean, this, obviously this is a terrible outcome. And as far as we know, harm was probably caused to patients as a result of this, and the algorithm was pulled. And I think this early warning story is something for us to be across the details of and be alert to. So algorithms themselves are not inherently racist or inherently biased. They don't have intentional wants, but they are algorithms that have learned from the information that has been fed into them. And so when you have a healthcare system, like in Australia or in the US or anywhere in the world, the information that is contained in there is all the historical data of care that has happened. And because we exist in a society where unequal access to care means that we spend less money caring for Black patients and white patients, we've done that historically. Because we've provided, unequal care to certain groups, this means that the data that we have in the healthcare system, using that to feed an algorithm, to train an algorithm, for an algorithm to learn on, the algorithm will replicate those biases. So it's a complicated concept. So it's kind of summarized here in a really pithy way. And I think, again, to really hammer this point home, if this is all we take away, algorithms that learn from humans, and that's the data that we're feeding into our algorithms. So learning from human data, also learn from human mistakes. And we have a long history of mistakes in healthcare. So we have disparities in testing and diagnosis and treatment. We have biases in race and gender and many, many others. And we've had a long history of failing to notice people who lack access to care. So there's certain people who are so vulnerable, they're not even in our healthcare system. We don't even have data on them. And the data that we do have is biased because of the nature of the healthcare system. So we need to be very cautious about building algorithms in healthcare, mental health or physical health, that are being trained on this data. And that's one of the biggest concerns, I think, when it comes to AI and future algorithms. It's worthwhile touching on some myths. You might not hold these anymore because the field's changing constantly. But again, just to reiterate, AI doesn't have intentional wants. It doesn't want to mislead us. It doesn't have perspectives on things. The majority of the systems that are out there have no technical architecture that enables reasoning. Again, they're just learned on the data, the information that they've been fed. It's a myth that deployed AI. So if you were to procure an algorithm to whatever it might be, and it's rolled out in the setting that you work in, it can't learn and improve over time. It's learned on the data that it's trained on, and then once it's deployed, it doesn't continue. Self-learning is not an inherent feature, and that's something we really need to be alert to. What's happening to this algorithm over time? We need to monitor and guard that. And I think at the moment, this is a bit of a concerning myth. At the moment, I do think, we think, the majority think we need to be pairing AI with humans. And if we're collaborating together, so a machine learning algorithm is predicting this, and then a human clinician is, providing oversight, we're going to get these great outcomes in healthcare. We're going to get these better outcomes. This is very dynamic, and so it could change in 2 weeks if a new paper is published. But for now, there's actually emerging evidence that when you put AI and human together, you get a worse outcome in decision making than AI alone or human alone. So AI models are very good at predicting and diagnosing in some instances, and humans are very good at that in some instances, but actually the combination of the two worsens the performance of both, and we don't really understand why. So there's still a lot that needs to be figured out there. I want to I'm not sure why I showed you this slide again. I think I wanted to just talk now, but yeah, I know why. So I just want to talk specifically about generative AI for a minute, because I know chatbots in particular are something that's really exciting and interesting and might have potential, particularly in the treatment of mental health conditions. So let's talk about generative AI. Worthwhile to just, if you don't already know, we have had chatbots in mental health for a long time. These were rule-based or decision tree driven, which again was that is a form of artificial intelligence, as you know, in that taxonomy. They were rule-based. They were quite predictable, but you could engage with them, and this is the most famous example, which was Eliza, and you can read there. Eliza's talking to someone who's having a difficult time with her partner, it looks like. And then, of course, Eliza on steroids is ChatGPT or any one of these other vendors, and this is now no longer, a form of AI, but specifically generative. And you've probably interacted with it extensively, so I won't go into the details of that. But really, the main point I wanted to make here is that we know now millions of people worldwide are using these for their mental health and well-being. So it's worth to kind of discussing what that means. This is a great advisory released by the American Psychological Association just a month ago. Again, encourage you to take a look at it. This is sort of our best thinking at the moment on whether generative AI can be helpful for people with mental health and well-being issues. And they're pretty strong in their statement. I've lifted this directly from the advisory. Their first statement is, do not rely on chatbots to deliver psychotherapy or psychological treatment. More specifically, general purpose chatbots. So what we mean by that is things like ChatGPT. They weren't designed, they weren't fed information, and they didn't learn specifically on data sets that are based on psychological treatment. They were fed information from the internet. They were fed information from places like Reddit. They were fed information from all sorts of areas. And APA come out very strongly and say these general purpose chatbots are not safe, and they were not created to deliver mental health care. Specifically created chatbots that are, designed by psychologists or mental health professionals and researchers, that we're still waiting on the evidence to see if they are safe to use. The evidence isn't there yet. And their third point was that they're very concerned about unhealthy relationships and dependencies between users. And I think they've got a long quote here, which I realize is very long, but I want to read it out because I do think it helps crystallize the concern that we have at the moment for generative AI and for folks with mental health and well-being issues. So I'll just read this out. The risk of creating unhealthy relationships with generative AI is compounded by the core architecture of many LLMs. And what they're talking about there is a large language model, which is the type of model that, you can use that synonymously with generative AI. So LLMs are often engineered for maximum engagement with users. And this is functionally similar to the infinite scroll of social media reels, which are designed to capture and hold attention rather than to achieve a specific healthy outcome for the user. These characteristics can create a dangerous feedback loop. So again, this is the American Psychological Association. I think this is very strong language and it's important. Generative AI typically rely on LLMs that are trained to be agreeable and validate user input. And we call this the sycophancy bias, which you might be familiar with. And while that's pleasant, they can be therapeutically harmful, reinforce confirmation bias, cognitive distortions, or avoiding necessary challenges. A user's unhealthy thoughts or behaviors can be validated and amplified by a sycophantic AI, potentially locking them into a cycle. And there is some early evidence of that occurring. So I think that's very interesting and important to keep an eye on. And I suppose as bespoke models, bespoke generative AI is built specifically for mental health, that might change. But for now, that's their very strong language around the use of these. You're the workforce, and so I wanted to talk to you about this. My answer is absolutely not, and here's my evidence for why. I don't know if you know this quote. I don't know if you know this person. This is Professor Geoffrey Hinton, and he said, "I think if you work as a radiologist, you are like the coyote that's already over the edge of the cliff, but hasn't yet looked down. People should stop training radiologists now." Very strong statement that he made. And he was saying that in reference to the fact that machine learning in particular, but also deep learning, had really started to come into radiology. And these algorithms were now able to detect things in X-rays and other images within 0.03 seconds, which was much, much faster than radiologists were. So he was saying this in reaction to how outstanding AI was performing in radiology and how he felt that that would affect the workforce. But the key point that I want to make is that Geoffrey Hinton said this in 2016. So he said this 10 years ago, and he went as strongly to say that radiologists will be obsolete in 5 years. And I'll just show you this image. I'm so sorry, the quality. I didn't realize the quality of this was so bad. This is the current supply and demand over the next 10 years for radiologists in Australia. So we have demand outstripping, so demand's in yellow increasing over time, and then the supply of radiologists in blue. So we have the exact opposite problem happening. We have not enough radiologists to meet the demand. And this is, I don't know if my colleague made this or this is just off the internet, but I thought this is funny. Because it teaches us, I think, to be very skeptical, particularly in this AI bubble, of any proclamations that are made from anyone, but particularly folk in Silicon Valley. So in 2015, we were promised self-driving cars in 2 years. In 2016, we were told we needed to immediately stop training radiologists. They needed to quit their degrees because they would not have a job. And now in 2024, we have radiologists, which we don't have enough of, in their regular cars driving to work. So that's I hope that analogy explains to you my position on whether chatbots will replace the mental health workforce. They will not. And actually the most near-term value, and one of the reasons why is because of what the APA has just said, which is that actually they're harmful. They can be harmful, chatbots. They don't challenge patients on their unhealthy thoughts. They're sycophantic. That's not what we want to improve people's mental health and well-being. That's the opposite of what we need. But I think the most near-term value for you as the workforce is what other people might see as quite boring, but I think is really important. It's just this augmentation of your clinical work. We need AI to reduce the friction that you experience every day in your clinical work. AI is not good at replacing relationships or acting therapeutically, but it should be used to deal with system-wide pressures and clinical work pressures. And it could do that right now. I mean, the technology itself is really incredible, and we could be using it in these ways. I think we're starting to, but we need to push for this more. So AI could support with your triaging and intake, ensuring there's measurement-based care prompts, creating patient-facing and caregiver summaries. I mean, there's an infinite number of ways it could be used to improve these sorts of things. Monitoring the service level demand, monitoring capacity in the back end, helping with scheduling. There's all sorts of ways I think AI could be really, really helpful. But of course, we've still got this gap. And so this is something we'll keep returning to. I'm going to speak for just a few more minutes and then happy to wrap up a bit early. I think, again, just paying a bit of attention to AI and why it is different from other sorts of tools. I think one thing to take away is that it's really important that AI is not just about the algorithm. At the moment, there is a lot of emphasis around the technical challenges of algorithms. We've talked a bit about what happens if the data quality isn't good, if there's inequity in the data quality, if the algorithm doesn't perform optimally, how to monitor it. We've talked a little bit about that, and we should continue to focus on that when we're developing AI. For mental health reasons, but we're really also interested in these additional challenges. And again, these additional spheres overlay the technical the technology and really represent those human factors. So another way to say this is it's not enough to just build an algorithm on good data and we're really confident that its performance will be optimal. Once we've done that, that's just the first step. Then we've got to figure out how to get clinicians to use it and consumers to use it. We have to make sure that it fits within the workflow. We have to make sure someone will pay for it, that the organization is digitally mature, and kind of list of challenges goes on. So I think just really summarizing that at the end of the day, it's that socio-technical solution that we need in digital health. And of course, underpinning all these things is building the trust, building the social license. I'm not sure we have the social license yet amongst the Australian public to deploy these tools, and that's a really important part of the story. So this is, I hope this has been useful. I guess this is the end for now for the next seminar. As you go through and you're listening to these other really exciting innovations, which I'm glad that you'll hear about, you can kind of always be continuing to ask before adopting a digital tool, what problem is this solving? Is it evidence-based for the population? Is it going to fit within my workflow or my colleagues' workflow? What are the risk and escalation pathways? And then always, of course, thinking about equity, who might be excluded or disadvantaged from using or not using this tool. So that's all, that's the takeaways, I think. I hope I've convinced you that digital mental health tools have tremendous potential. I'm certainly not a techno-pessimist. And we really do have right now very difficult issues in Australia's mental health care system. If we're going to be successful with digital mental health, it will be a socio-technical solution, not just a technical solution. I'm convinced that trust, evidence, quality, usability, and funding mechanisms, again, we barely talked about funding, but it's a huge problem, are these barriers to the adoption of digital mental health tools. And we need to work better with the universities, and we need clinicians and universities and consumers working together, because it's going to take partnerships. It's going to take new evidence methods. It's going to take a bit of a revolution, I think, really, in that space in order to digitally transform. And of course, AI is exciting, but it brings new risks and new opportunities. And I do think without care, much like that case in the United States I told you about, we will entrench health inequity if we don't do that in a considered, safe way. So that's all I had to say. If you're interested in hearing more about the centre and what we do, here's a QR code and some information. I know that Molly's hoping to get one last evaluation from you, and so maybe I'll hand over. I'm not sure what I should do now, actually. Should I hand over to Molly, or what should I?
Sure, thanks, Olivia and Belinda. Did anyone, if you have a question for them in the last couple of minutes, please do pop it into the chat. Belinda's been frantically answering them in the chat as we've been going along. I'm just going to share the QR code for our evaluation. So if you can take a minute to do that. And also, I'm going to have another go at, I think I've worked out what my problem was with the poll. I'm really keen to establish a case for understanding how much more we'd like to know as a sector about digital health. I'm hesitating because I'm trying to operate a thing at the same time. So, so the polls are about what are the barriers and what do you want to learn more about. So I've just popped up one that is what are the barriers to using digital health tools in your work? And if you have other ones that I haven't thought of that you want to comment in the chat about, that would be great too. But yes, please join me in thanking, with a little round of applause from our React, our speakers, Dr. Olivia Metcalf and Dr. Belinda Davey. We do have a question from Michelle. How can we produce AI that does not reproduce human bias? Interesting question. Do you have anything on that, Belinda or Olivia?
Yeah, it'll all come down to the data. And I read a really good paper the other day that says everybody wants to do the model work, not the data work. And I love that phrase because I do think it's one of the problems at the moment. Belinda's a data scientist and she's laughing. Everybody wants to build a model because building a model is very exciting and fun. And we shouldn't, I'm not saying we should stop doing that, but we need to invest much more time in the quality of the data, particularly in places where there is inequity. So if we were able to build a data set that really truly represented and didn't capture inequity, theoretically we'd build a model that wasn't able to discriminate. But I think that's the challenge, is where do you get these data sets from? And I don't know the answer to that. I think that's still work that needs to be done.
Great, thank you. Issue is cost to consumers. Issues is cost to consumers. Data is expensive for them to use. True.
Yeah, I'm not sure if, I think maybe Erin, I'm not sure. I hope I've got this right, but I think what you're talking about is if you're using an app that requires someone to access the internet or download information, is that what you're saying? And then the burden's on them to spend money on their plans. Yeah, it's really tricky. And I saw a study the other day that really worried me, that said for Australians in low socioeconomic categories, they can be spending up to 10% of their income on internet access. That's just how much these plans can cost, particularly in really rural and regional areas. So yes, I agree. I mean, this is radical, but maybe internet access should be subsidized if we can argue that it's a health condition, right? Like we do subsidized care for folk, and I think that if we make the strong case that digital health is a part of the healthcare system, it's not a nice to have, it's necessary to have, then maybe we could make the case that internet access is subsidized. We know that in some areas internet access is subsidized for families who have young school children, because digital access is fundamental to being able to access schooling at the moment. So maybe we're looking at a future where internet access is subsidized for health reasons. I don't know, that's a radical concept, but that would be one way around it.
And Dr. Gillian Robinson's asking about consent. Well, she just made a comment about consent, but I think she'd like some opinions about that.
Yeah. Sorry, I read that as something she was wanting more information about, and certainly the fourth in our series with Dr. Piers Gooding is looking at ethical and legal issues around privacy and consent and how we use AI. And I'm just looking at the other one, uncertainty about which tools to trust. 71% of our respondents have said is an issue. And our session next Friday, is on evaluating digital tools with Dr. Lou Ferrer from ANU. So that will be a very interesting one in terms of assessing as clinicians which apps and digital tools are the best ones to use. Olivia and Belinda, thank you so much for your time. It's been really fascinating and a great way to kick off the series. So thanks again for joining us.
Thanks for having us, everyone. Take care.
Thank you. Thanks, Olivia.
Bye.
Bye.